All right, let's jump into antipsychotics. They're most commonly used for treatment of schizophrenia. We're going to talk about them in subsequent modules. They're also used for bipolar disorder, treatment-resistant depression, anxiety, and a few other um, psychiatric illnesses. But we're gonna jump right into it. So I'm gonna skip a lot of these first slides because you're gonna get these in your other classes. You know, the DSM-5 criteria for schizophrenia, things like that, subtypes. But we're gonna jump into just a few things that I think we need to know about. So the symptoms of schizophrenia, because these are going to come out in how you're treating and what side effects medications can cause. The positive symptoms of schizophrenia are symptoms that the disease gives a patient. It's a good way to remember the positive symptoms. So something it adds to the patient. So it's delusions, hallucinations, paranoia, and hostility. So a delusion is a persistent belief in something that everyone else knows to be false. So that is that, if I believe that, I am the king of the world, or I am, whatever those false beliefs that someone has, that they are the next coming of, the Messiah, or they're the president, or, kind of what you see, stereotypical on TV of a psych patient, that false belief in something. So delusions, you can have temporary delusions, or you can have fixed delusions that no matter how much medication they're on, that delusion stays, and they just kind of learn to manage it. You have hallucinations, which are that are false senses that are there. So it can be any sense. A lot of people think of hearing voices and seeing things, but you can also have taste. A taste in your mouth that's not there. That I'm tasting metal, I'm tasting blood, I'm tasting cake, whatever it may be. It doesn't have to be terrible, but that they believe that taste is in their mouth. It can be olfactory. We have a lot of them that they'll smell smoke or something like that. And then it can be tactile. They feel like, we had one patient who felt like somebody was pressing down on her shoulders a lot, and she kind of had she was feeling a tactile hallucination. So those are positive symptoms. Another category of schizophrenia is negative symptoms. You'll see these a lot with when we're talking about schizophrenia, but also the treatment of schizophrenia. They come back as side effects of medication also. So you'll have a flat affect, a lack of facial expression, avolition, alogia, anhedonia, and asociality. So you are getting a patient who has a lack of motivation, a lack of pleasure seeking. They don't care to do the hobbies that they used to do. One of the psychiatrists explained it to me really well that if you, in the middle of the summer, if you went into one of our day rooms and you could turn the air conditioning down to 40 degrees, a lot of the patients would not have the motivation to get up and go get a jacket. They're just going to sit there and deal with it. So you have a decreased fight or flight response. They're happy to sit on the couch and do nothing. They just don't have that motivation to go out and make personal connections or to do things that they used to enjoy. And then the last category of symptoms that a lot of times isn't thought about so much is the cognitive symptoms. So a lack of attention. So they have a hard time focusing on one topic. Sometimes that can be confused with unable to focus because of a hallucination. You'll notice in treating and with patients, especially of auditory hallucinations, that it's really hard it's really hard to just ignore that. Some of the patients I've seen, it's almost like an obsessive compulsive tick. Like they can avoid it for so long, and then they have to respond to the voice that they're hearing. But they do have a lack of the inability to pay attention to things. A working memory is Um, Working memory is usually impaired with patients with schizophrenia, especially patients who've had multiple episodes. Um, that is a working memory is that you can memorize things, but you have a hard time putting that into practice and applying it to a new situation. So a very basic explanation is that I can teach you that 2 plus 2 equals 4, but you have a hard time of taking that and applying it to other numbers to add. But as long as I say what's 2 plus 2, you'll say 4. And you know that part. And then executive function is a lot of times impaired with patients with schizophrenia. And we know that gray matter is actually lost with subsequent episodes of schizophrenia, and the longer it goes uncontrolled. It's been proven. You can see pictures. I believe they're in your book. If not, you can. There's plenty online that they'll actually show images of the brain, and it's almost kind of like after multiple episodes of schizophrenia, it's like that old what do you call them? The commercial they used to have of "This is your brain," and then "This is your brain on drugs," where it's atrophied. It has a very similar look to it. So we're going to skip over the different subtypes and go right into treatment principles. So the goals: early diagnosis and early treatment. Right now, treatment is focusing on is thankfully shifting to long-acting injectable antipsychotics. That is because we know that there's finally concrete evidence. We'll talk about this in a little bit. Concrete evidence that long-acting injectables have better compliance and have better outcomes than oral antipsychotics, even oral of the same antipsychotic. It keeps people out of the hospital. It keeps people from relapsing for a longer time. So the mainstay is long-acting injectables, and a lot of them have patient assistance because they can be expensive. So one way or the other, we can get it paid for. Another goal is reducing symptoms, minimizing side effects because there will be some. And one thing, I know this sounds like an exaggeration, and it is, but one thing I like to tell people is to remember that a medication is a substance you put in, or even a poison you put in your body to prevent it from doing what it wants to do. There's hardly any clean medications. Your body has an excess of dopamine. It wants to have these hallucinations and delusions, essentially. So if by blocking dopamine, you're going to block dopamine everywhere, it's also going to hurt the areas that we need dopamine to function. And we'll talk about those side effects coming up. There are no psych medications and no medications in general that don't have any side effects or that potential. We want to improve quality of life, and we want to prevent suicidality. Antipsychotic treatments may continue to ameliorate symptoms of schizophrenia if maintained for an extended period of time. Continuous maintenance of antipsychotic medications results in a 70% reduction in risk of relapse. And gray matter loss is worse in patients with a longer duration of untreated psychosis. And I'm seeing that a lot now at our facility because we have a lot of patients who have been there for quite a while, multiple episodes, and they're kind of hitting their 50s and 60s, and they are more like late 70s, 80s, and 90-year-olds in their functioning. A lot of them are having dementia. A lot of them are having just that we're having to treat them like they're much older because of that gray matter loss and the multiple episodes of untreated psychosis. A lot of them also have illicit drug use in their past. They've been trying to self-medicate. So that only makes it worse. So treating them early, treating them with adequate doses of long-acting injectables is the goal. There is no cure for schizophrenia. Delusions are the hardest symptom to treat, and they may not go away. It could take 4 to 6 weeks to clear psychosis. Agitation and sleep disturbances will improve initially, and treatment is going to be lifelong. There are non-pharmacologic treatments. You can read through these, but cognitive adaptation training helps the patient compensate for cognitive deficits. And there are some really good examples there. I would definitely also focus on getting your patient in for psychology treatment, psychotherapy, because it's wonderful for patients. They really need to work on coping skills and this adaptation training, and what can they do to help themselves be successful. Compliance therapy is huge. The biggest reason therapy fails in patients is because of noncompliance. You have a patient who does not think they're sick, does not need medication, according to them, and you're giving them a medication that causes side effects that they don't want. Now, we know that most people aren't compliant with medication that they ask for. If a patient comes into your office who clearly has a viral infection and is not leaving without an antibiotic, we all know, we've seen those patients, they're not leaving without that antibiotic. So you write them amoxicillin 500 BID times 10 days. How many days do you think they take that medication? They take it 3 or 4, they feel better, they quit taking it. So a patient who even wants their medication isn't compliant. So a patient who doesn't want their medication, doesn't think they're sick, is definitely not going to take their medication. So with using compliance therapy, you underscore the importance of the treatment alliance between patient participation. You get a lot more buy-in with anything, with treating anything, if the patient feels like they're acknowledged and that their opinion matters. So you want to acknowledge negative treatment experiences. Discuss how denial of illness and need for treatment has affected their social and lifestyle consequences. Discuss the tendency for patients to stopping the medication when they're feeling better and why they need to continue. Emphasize the importance of staying well to fulfill other goals. You can factors that can contribute to noncompliance. Lack of insight, that's a huge one. Patients' perceptions about lack of treatment benefits and risk. That is not just with schizophrenia. Patients who, if you cannot physically feel or see the difference in your treatment, then most people don't take it. It's really easy to convince somebody to take a painkiller because they have pain, then they don't have pain. And when they stop, their pain comes back. But it's hard to get your patients to stop or to be compliant on blood pressure medications, because most of the time they can't tell their blood pressure's high. Diabetic medications, because unless they are really high and they're peeing all the time and having other symptoms, they don't know that their blood sugar is high. So they don't see the benefit of being compliant all the time. And your patients are going to see that too. Unless they are back to baseline, they're not going to see the benefit as they're gradually coming out of those hallucinations and delusions are subsiding. Cognitive impairment can contribute to noncompliance. Physical barriers such as financial or lack of transportation, that is huge. You have patients who cannot usually keep a job. They have a hard time getting benefits. They are not advocates for their own health. They're just not. They are. That's one, in my opinion, that's one reason why mental illness has been just pushed to the wayside and forgotten, and the funding just keeps getting cut more and more, because they don't advocate for themselves, because they don't think they have an illness. So if I don't want to get treated, why would I ask for more treatment? Why would I ask for more funding? The squeaky wheel gets the oil, and there's just not enough. There's just not enough squeaky wheels. So, and these medications can be expensive. These newer antipsychotics are $1,400 to $2,800 a month. So they're very expensive. So we definitely need to help patients get around these barriers. Cognitive behavioral therapy is very helpful for patients, especially with coping mechanisms. You have other strategies to improve adherence here. Other options, I'll let you read through these, but they're great non-pharmacologic treatment. I would also focus on support groups and family education. NAMI, or the National Alliance for Mental Illness, is a great resource for your patients and family members of patients. They have support groups for family members of of patients with mental illness. They have support groups for providers, because it can be draining, and so it's great to go and talk to people who are also in that same situation. Now, antipsychotics, the big reason why we're having this lecture. Antipsychotics were discovered in the 1950s. The first one being chlorpromazine, which was used during surgeries. It was observed to be having an antipsychotic effect. That started the group of medications called typical antipsychotics. So all antipsychotics have an equal effect on positive symptoms, the delusions, hallucinations, and those. All antipsychotics have equal effect at equivalent doses across population, not per patient, but across the population. They're all equally effective. Some patients may respond better to some than others, but overall they have the same effect. Blockade of dopamine, which is what typical antipsychotics do, they are antagonists at dopamine receptors, may also cause secondary negative symptoms or make negative symptoms worse. And your typical antipsychotics or first generation antipsychotics block dopamine, alpha-1, histaminic, and muscarinic receptors. So you get blocking of dopamine, which is where your therapeutic action comes from. That's also where you have side effects, and you have side effects from alpha-1, which can cause orthostasis, histaminic, which can cause sedation and weight gain, and a muscarinic. So, So dopamine is what mediates the normal reward system in the brain. So obviously blocking that dopamine is why we get those secondary negative symptoms. It also depends on what path we are blocking it in. So dopamine has 4 pathways in the brain, which so if we block it one, it helps with the delusions. If we block it in another, it can worsen cognitive symptoms. If we block it in the tuberoinfundibular, it actually causes hyperprolactinemia because dopamine keeps prolactin levels low. So there's a lot that goes into these medications. All antipsychotics have a black box warning for patients with dementia. Antipsychotics will increase the risk of death compared to placebo, and this is usually due to cardiovascular or infectious events. This is all antipsychotics, from the oldest to the ones that just hit the market, including pimavanserin or Nuplazid, which is being studied for patients with dementia-related psychosis. It still has that risk. So how do you select a medication? You select a medication based on prior response to medication. Was it successful, or did they not respond to it? Past experience of side effects. A lot of them, if you have some that cause way too much sedation, some other ones that to ignore, and we'll talk about that in just a minute. Side effect profile of prospective medications, the patient's preference, low cost, I don't want to be sedated, I want an injection, and the available dosage forms. Does it come in an orally disintegrating tablet? That way it's less likely to be cheap. Is there an injectable version? Is there an immediate acting injectable version or a long acting injectable version? You also want to consider the following side effects: weight gain, diabetes, hyperlipidemia. Those are big for antipsychotics. They're all going to cause some kind of risk for this, with the biggest risk coming from clozapine, olanzapine, and quetiapine, or Clozaril, Zyprexa, and Seroquel. You also can have QT prolongation. Now, the risk of QT prolongation is a lot lower than what it used to be, because there's medications that are no longer on the market with the biggest risk. And this is later on in your notes. It has the comparative risk. Geodon being the highest at about prolongation of about 20 milliseconds, and another risk being Haldol, but it's only high dose IM Haldol that is really a large risk, but that's 5 to 10 milliseconds. The rest of them have a risk of usually about 2 to 8 milliseconds. So it's not a big issue unless your patient already has an arrhythmia or is on several medications that can prolong a QT interval. Hyperprolactinemia is a side effect. Blockade of dopamine causes hyperprolactinemia because dopamine keeps prolactin levels down. EPS is more common with your dopamine blocking medications or ones that have high affinity for dopamine receptors. Tardive dyskinesia, cataracts, and myocarditis with clozapine. Those are potential side effects to keep in mind. If you're looking for guidelines on antipsychotics, you can see there aren't any that are fairly new, so they don't take the new medications into account. But for the most part, the new medications are atypical antipsychotics or second generations. They just fall right into that class where Zyprexa and Seroquel and Geodon are, except they're not used as often because they're way more expensive than the other ones. So you can apply those medications to these guidelines wherever the atypicals are listed. So in clinical practice, what treats these symptoms? So positive symptoms, all antipsychotics are effective. Negative symptoms, if they have strong negative symptoms, you want to try to avoid typicals or first generation antipsychotics, and you want to avoid high dose atypicals. So focus on medications that have more serotonergic activity and less dopaminergic activity. For cognitive symptoms, you want to try reducing medications for side effects or other symptoms like anticholinergics, which we give for extrapyramidal side effects, and benzodiazepines for anxiety. Affective symptoms, you may need to augment with a mood stabilizer or an antidepressant. We see that all the time with patients who also have manic symptoms or depressive symptoms. And suicidal symptoms, clozaril and lithium are actually proven to reduce suicidality in patients with schizophrenia. They're the only two that are approved for that. So those would be good options, either lithium added onto it or clozaril as the antipsychotic of choice. So typical antipsychotics block dopamine, alpha-1, histaminic, and muscarinic receptors. Dopamine blockade causes relief of positive symptoms and side effects, and alpha-1, histaminic, and muscarinic blockade causes side effects also in varying degrees. And what you're gonna have to understand with antipsychotics is it is all a continuum. It's a range. This one has low alpha-1 receptor activity and high dopamine blockade. This one has a medium level, a medium potency for this, but a high histaminic. So knowing what the receptors do, you can apply it to any new antipsychotic and get a good guess on what the side effects are going to be and the activity. Atypical antipsychotics, or your second generation, also have an effect on serotonin receptors. They still affect the receptors listed above, but they also add in serotonin, and that is the difference between typicals and atypicals. All your newer antipsychotics, basically clozaril is the first atypical. Anything clozaril and newer is an atypical. It has some type of serotonin receptor activity somewhere on that continuum. But the primary target has always been dopamine. For a long time, has been dopamine receptors for schizophrenia. We know that by decreasing dopamine activity, we get a decrease in psychotic symptoms, positive schizophrenia symptoms. We also know that by increasing dopamine with medications for EPS or for Parkinson's, that we can get positive psychosis symptoms. So we know that dopamine plays a role in this. So the goal from this chart, which is from your book, is that we need a blockade. There's a fairly narrow window that shows where this green line is where your antipsychotic effect threshold stops. But then not much higher than that is where you start to get extrapyramidal side effects or those movement disorders and hyperprolactinemia. So there's a careful balance that we have to walk where we don't use nearly the high doses of antipsychotics that we used to, because we know that there is a ceiling effect for that, and then we're just increasing the risk of side effects. So the dopaminergic tracks and their effects. So there's 4 tracks of dopamine. The nigrostriatal its function is the extrapyramidal system. So by using a dopamine agonist, we're increasing the risk of movement disorders or those extrapyramidal side effects. The mesolimbic causes arousal, memory, stimulus. Those, by antagonizing dopamine there, we get relief of positive symptoms. The mesocortical, blocking dopamine there, causes cognitive side effects and blunting of emotions, or those negative side effects. And the tuberoinfundibular causes an increase in prolactin. The downside is with blocking dopamine, with all the medications we have right now, we can't block dopamine with any of our antipsychotics in just the mesolimbic tract. We're going to block dopamine in all of them or none of them. So the way to get around some of these side effects is to possibly focusing on medication that doesn't target dopamine, but targets serotonin or other neurotransmitters, with the goal of causing downstream regulation of dopamine. So we block serotonin at a certain receptor, which then blocking that serotonin down the neuron, like we talked about in the last module, causes less dopamine release in the neuron in the mesolimbic tract for dopamine, causing relief of positive symptoms but less side effects in the other one. So that's the thought behind that, and why you can block serotonin and other neurotransmitters and hopefully get a downstream regulation. If we could just block the mesolimbic, we'd have great efficacy, but right now it's just not possible. Antipsychotics also target alpha-1 receptors, which can cause orthostatic hypotension and drowsiness, histaminic, which causes weight gain and drowsiness, and muscarinic cholinergic, which causes dry mouth, blurred vision, constipation, and cognitive blunting. So again, all of your antipsychotics are going to have a continuum of this receptor, and when we see further on, and you'll see in your books that there's it varies in receptor affinity. So they'll use it as they'll show it as plus signs. So is it does it have a small affinity, so plus, so it hits those receptors, but maybe not enough to cause the side effect or have an effect, or up to 3 pluses where it acts on that receptor and you're going to see some kind of effect, or you have a 2+ middle ground. So that is where you can guess what kind of side effects these medications are going to have, and then potentially use that for something for the patient. Maybe you need a patient who's to be a little drowsy, or maybe they need to gain a little weight. So maybe you can use it. So first generation antipsychotics focus on dopamine 2 receptor blockade potency. Now there's 5 dopamine receptors. We focus on dopamine 2 for control of positive symptoms. So these are your most common first generation antipsychotics, or typical antipsychotics. The ones you've probably heard of are probably haloperidol or Haldol and fluphenazine, Prolixin. I'm gonna try to call them by their generic names during the lectures, because a lot of them are becoming available generic, and that way we're not having to talk about 2 of them. But haloperidol and fluphenazine are high D2 blockade potency, so they have less sedation but a higher risk of movement disorders. So there's not as much of that alpha-1 histaminic muscarinic receptor activity. Going down the list, you reach the bottom of chlorpromazine and thioridazine, which are low D2 blockade potency, but they're higher in alpha-1 and histaminic, so they have more sedation and a lower risk of movement disorders. Now, they're still just as effective, but they have to be taken to much higher doses to get an effect, and so you're probably going to see those side effects by the time you see efficacy. You also have dosing equivalencies for those, and you can see here that this one is an equivalency to Haldol. So everything has an equivalency to Haldol 5. It just depends on what dose. So obviously the higher the dose, like this chlorpromazine, is a lower potency medication. So 250 milligrams equates to 5 milligrams of Haldol, whereas fluphenazine, which is just as potent, 5 milligrams equals 5 milligrams of Haldol. So that's how you can judge their potency, is like what is the average or the therapeutic dosing range of these medications. So again, this is just going over your first generation antipsychotics, what to expect with the high potency and the low potency options. Most are metabolized through cytochrome P450 2D6. That's important to remember. Typical or first generation antipsychotics go through cytochrome P450 2D6, which means they are going to have some drug interactions. Most half-lives are around 20 to 24 hours, which means it'll take about 5 days to get to steady state and 5 days to get out of your system. And there's no well-established therapeutic levels for most of these medications. Now, the one exception could be haloperidol, which there's some evidence for. Don't draw a Haldol level. Some places you'll have some. It'll say there's modest evidence. You can draw it, but all it really tells you is the patient taking the medication? It doesn't. There's no suggested range. It doesn't predict efficacy or side effects. It just tells you, is there Haldol in the patient's system? So there's no well-established therapeutic range for most of these medications. Here are your expected side effects with these. So you're going to have extrapyramidal side effects, cognitive side effects, hyperprolactinemia, QT prolongation, temperature dysregulation, and then your low potency typical first generations will have those antihistaminic, anticholinergic, and alpha-1 blockade side effects. Your EPS, you're going to have pseudo-Parkinsonism. So they're going to look like a Parkinson's patient with the tremor, the shuffling gait, those side effects. You could have tardive dyskinesia, which is a constant involuntary muscle spasm. You could have dystonia, which is there's really good YouTube videos of it out there, where a patient's muscles basically lock up, and it's usually in the neck, and you can actually see like a time lapse of somebody getting a Benadryl or a Cogentin injection to where that muscle slowly loosens up. And then akathisia is a restlessness, or some people say it's like like ants crawling under your skin. Like it's a constant tingling that only is alleviated by movement. So the patient looks, so they're constantly fidgeting when they're sitting down. You'll see them shuffling their feet, adjusting in the chair, constantly moving, and that's the only way that alleviates that. And that's a big predictor of noncompliance, is if patients develop those, because they're not going to keep taking it. Here are treatments for EPS, whether the patient has akathisia, dystonia, or pseudoparkinsonism. If a patient does develop these, you're probably going to end up having to change the medication to something else unless you have no other options. If they develop tardive dyskinesia, you absolutely stop the medication and switch it to something else, because that tardive dyskinesia can become permanent if it's given so long. But these other ones do have some options for treatment. Prolixin decanoate. It is a long-acting injectable version of Prolixin or fluphenazine. You're going to get it administered every 2 to 3 weeks with a maximum dose of 50 milligrams. And you can experience dose dumping, which is when the patient gets a big dose of medication in the first up to 24 hours of the medication. I don't see that a whole lot, but it is a possibility. So if the patient seems sedated, it could be because of that dose dumping. Now, converting someone to Prolixin decanoate, for stable patients, you want to multiply the oral dose by 1.2 and round to the nearest 12.5 milligrams. Overlap with PO for 2 weeks, or give weekly doses for 4 to 6 weeks without PO overlap. Acute patients, you may want to multiply the total daily dose by 1.6, and then you would give it every 2 weeks for the medication. So when it says overlap PO for 2 weeks, you can do it longer. I've seen some references that say to do it for 6 weeks, so that prolix and decanoate gets to steady state, not just starts to reach the bloodstream. But you may want to gauge your patient and see how they're doing before you just cut the PO. But definitely try to get them off. You definitely get them off the PO, because you don't want the risk of having too high of a dose, and leave them having to take both medications. Haldol decanoate is a long acting version of Haldol. There's no dose dump like Prolix and decanoate. You multiply the oral daily dose by 10 to 15 with a maximum of 450 milligrams. It's given once a month, but may need to be given more frequently for symptom control. And you overlap with PO medication for 4 weeks. Now, with Haldol decanoate, no more than 100 milligrams can be given in the first injection. If the patient needs more than 100 milligrams, you give 100 milligrams in the first injection, and the remainder 3 to 7 days later, and then the following month you can give the full dose. So, with Haldol, we usually give the oral maximum dose now is usually about 45 milligrams a day. So if you were going to convert somebody to Haldol decanoate, you would multiply that by 10 to get 450 milligrams. Obviously, you wouldn't do it by 15, because 450 milligrams is the maximum. If you multiply it by 15, it's going to be much, much higher than that. So you can do 450 milligrams, and then you would give 100 milligrams, and then 350 milligrams in 3 to 7 days. Now, both of these, the Haldol and the Prolix and decanoate, there's nothing special about these injections. They're very simple. They are Haldol or Prolixin with suspended in sesame oil with a preservative added to them. And so as they're injected, they can cause some injection site reaction when they're given. And as the oil is broken down by the body, it releases into the drug into the bloodstream. That's why there's that variability in the 2 to 3 weeks for Prolixin, or I've seen from 2 to 4 weeks with Haldol. That's why it varies, because everybody breaks that oil down at different rates. So we've seen a lot of, especially if you're not doing like a Z-track injection and swapping out the needles after drawing it up, you can get an injection site reaction, because that oil is more abrasive to the skin than the newer second generation antipsychotic long-acting injectables, which are water-based. That doesn't mean you don't use Haldol and Prolixin, but just make sure you take extra precautions and good techniques when giving these injections. So second generation antipsychotics, these are used a lot more now than your first generations. They're especially now that there are generic options available. They're also known as atypicals. In general, they cause less extrapyramidal side effects and less worsening of negative symptoms. Now, depending on where you read, they'll say that they make negative symptoms better, they improve them, or some places will say that there's just a less of a worsening of negative symptoms. And I think that I tend to agree with the less worsening, as opposed to just making them better. They just don't make them worse, I think. There are more metabolic side effects with these medications, which could be one of the reasons why that most patients are compliant with these a little bit longer than your typicals, because metabolic side effects are more gradually seen than a movement disorder. Usually you're kind of shocked, like, wow, I've gained 20 pounds in 6 months, as opposed to my foot is shaking and it won't stop right now. So that may play a role. What makes an antipsychotic atypical is the 5-HT2A or serotonin 2A antagonism. And then each one has a slightly different receptor profile that may or may not contribute to better outcomes. They're used in many psychiatric disorders, so schizophrenia, depression, bipolar, and they differ from first generations through varying degrees of serotonergic and dopaminergic activity. So we said that second generations have metabolic side effects. So ADA and the APA came up with a consensus for all second generation antipsychotics should be monitored, should be monitored for metabolic side effects at the following regimen. You should look at, when you begin, you should start at personal or family history, weight going up to quarterly, waist circumference yearly, blood pressure yearly, fasting glucose and fasting lipids quarterly, and then up to yearly. And then you would assess the patient's risk. We actually, inpatient, we do it quarterly. We're usually drawing blood levels for, drawing labs for lithium and Depakote anyway, so we will tack on at least an A1C, a fasting lipid panel to those quarterly, because we want to stop the metabolic side effects before they get too bad. But at least yearly is where you'd like to monitor these patients. So, getting into our first atypical antipsychotic. Clozapine was the first one developed. It is the best in terms of efficacy for refractory illness, and it has a low incidence of extrapyramidal side effects and tardive dyskinesia. It is proven over and over again that clozapine is the most effective antipsychotic we have on the market. It's not even negotiable. It is proven at longer time to non-compliance, longest time to negative outcomes, hospitalization, a longer symptom control, but the side effects limit the use. So it can cause orthostasis, sedation, anticholinergic effects, which could be good and probably why it has a low incidence of extrapyramidal side effects and tardive dyskinesia, because anticholinergic would help prevent that. Sialorrhea, metabolic changes, it decreases your seizure threshold at high doses. So that is 600 milligrams and above is where you're going to get that decreased seizure threshold. Can cause agranulocytosis, which is why we have to monitor the absolute neutrophil count. At the least frequent, it has to be monitored every 4 weeks. At least every 4 weeks, and it starts out weekly. So that's a blood draw every week that the patient that'll have to get. A lot of patients are not very happy and don't like to be compliant with that one. There are box warnings for agranulocytosis, which that risk is greatest within the first couple months of therapy and then drops off drastically. It's still only a 0.5 to 2% risk. I think that the general medical population thinks that it's a much higher risk. It's not dose dependent. It's usually happens at the beginning of therapy, and then the risk dramatically drops. I think it's like 0.03% after the first couple months. So it's not a big risk, but because it can be so bad, we still have to do that monitoring. Clozaril can cause myocarditis. Can cause seizures, orthostatic hypotension, and cardiomyopathy. So because of that, there is people tend to stay away from Clozaril or use it as a very last line option. Now it is also because it has an orally disintegrating tablet version. It's a Fasiclo, which could help with compliance, and it's very loosely bound to D2 receptors. So that's one of the kind of the last receptors that it works on is D2, which is why it's the drug of choice for patients with tardive dyskinesia or for Parkinson's. You can get serum drug levels to check for toxicity. Again, it doesn't tell you if it's a therapeutic dose or not, but it will check for toxicity, and they're going to check a clozapine and a norclozapine level. So that's the active metabolite of clozapine, which will tell you, is it metabolizing clozapine to norclozapine and then metabolizing the norclozapine to be cleared fast enough. So it can tell you if there's a drug interaction, is that why they're becoming toxic, or they're having more side effects than we thought, because that'll help you, can help you measure that. and you have to do a slow titration due to orthostatic hypotension risk. Most people think that the slow titration, which is no more, you have to increase at no more than 25 milligrams a day. Most people think that's because of the agranulocytosis, but it's not. It's actually the orthostasis. And after 5 days of after a patient's been off it for 5 days, you're supposed to restart the taper, because if I've been taking 400 milligrams of clozapine and I come off it for, say, 2 weeks and you put me back on 400 milligrams, I'm going to fall out when I stand up because it has that much orthostasis. So that is a risk, but that's why you do a slow titration. So clozapine is the only one approved for treatment-resistant schizophrenia. It is also approved for the prevention of reemergent suicide events. It's the only antipsychotic with that indication. It has a very low incidence of EPS and may even improve current symptoms, and is the only antipsychotic shown to reduce suicide risk in schizophrenia. It may decrease violence and aggression, and has the most complex receptor affinity. So it is very effective, a very effective medication, but because of the monitoring requirements and the side effects, I think it's underutilized. So here's the receptor affinity for clozaril. You can see all these 5-HT2. Those are the different serotonin receptors. You have a partial agonist at 5-HT1A. You have the M's are muscarinic, H is histaminergic, alpha receptors, and then your dopamine receptors. Clozapine has a lot of drug interactions. Going back to the receptors, this is one of the most complex receptor affinities that you're going to see on an antipsychotic, that it hits all of these. And in your book, it'll also show you the receptor affinities where it's mostly serotonin, then these alpha and muscarinic, and then dopamine at the end. So it's a very low dopaminergic receptor affinity. So usually you're just getting these, the serotonin and the alpha, which probably is why it's doesn't cause EPS, but also has a very good efficacy and longer time to discontinuation. Has a lot of drug interactions, a lot. Any new medication you should check to see if it has a drug interaction with clozapine. It is a metabolite of cytochrome P450 1A2, which means its metabolism induced by smoking and by caffeine, two things that our patients with schizophrenia are going to use. It is inhibited by a lot of medications, one being Cipro, an antibiotic. So you could have a patient who gets put on a 10-day cycle of Cipro, and all of a sudden their clozapine level shoots through the roof, their serum level. You could be put on Luvox for OCD. It's an SSRI. That it would go up. It also goes through 3A4, which has way more drug interactions than you can remember. But it can be induced by carbamazepine or Tegretol, which is used for bipolar disorder. It's inhibited by Luvox also and ketoconazole. So maybe they have a fungal infection and they're put on a short course, and it ends up inhibiting the metabolism of clozapine. So their level is going to go up. They're at a higher risk of seizure and side effects. So the risk of agranulocytosis, the risk at 1 year is 1.3%. It peaks between 6 to 18 months, and then during the second year it drops to 0.07%. The overall risk of neutropenia is 2.9%, and the risk of agranulocytosis is 0.8%. So it's a lot lower than what most people think, but even though it has that risk, we are required to go through the REMS monitoring program. Yeah. I want to make sure I had a slide on that next. It also decreases the seizure threshold, which again is important to remember. If they have an active seizure diagnosis, and it increases the risk at doses 600 milligrams and over. So over 600 milligrams or any drug interaction that would increase the serum level to similar to 600 milligrams or over is going to decrease that threshold. Also, if they're on other medications that decrease the threshold, like Wellbutrin or bupropion as an antidepressant, that combination has to be taken into account also. The clozapine REMS program is one that the prescriber must register and sign the patient up for. It is on this website. There used to be one based on every manufacturer of clozapine. They combined them all into one to this website. It's not the easiest website to use, but anytime I have trouble, I call and tell them what I'm trying to do, and the people are actually very quick to fix anything. The pharmacy that dispenses the clozapine must sign up also. They are not allowed to sign the patient up for you. It has to be the prescriber or somebody who works under that prescriber. All the pharmacy is allowed to do is they will type in the patient's name and date of birth, and it will say, yes, you can go ahead and dispense this medication, and how many weeks supply they can dispense. You have to report the absolute neutrophil count and the dose of medication the patient's on weekly for 6 months. Then you can go to every other week for 6 months, and then you can go to every 4 weeks if the patient has not dropped below an ANC of 1.5. If it drops below 1.5, it requires more frequent ANC monitoring, even up to daily, to keep them on it. So, because of this, most patients get tired of this monitoring, and they actually will say that I'm not going to do the blood draws anymore before they'll actually stop the medication. Because for most patients, it seems to be fairly tolerable at adequate doses. But it's usually the blood draws that cause issues. A lot of the group homes that are out there now will actually have a pharmacy that they use. They'll actually kind of like not a mail order, but they'll deliver it. So I know there's one in Charleston, South Carolina that handles a lot of group homes. You know, they'll do it and then they'll just mail the medication. There's one somewhere in Columbia that does it. So they'll actually, it's kind of like one of their specialties is Clozaril REMS monitoring and ANC monitoring, and so they'll assist with that. So it's a very effective drug, but it's a lot of work to get somebody on it. The next atypical is risperidone or Risperdal. It is known as the typical atypical. It has a receptor affinity very close to our typical antipsychotics. So it tightly binds to D2 receptors. Now, knowing that it's the typical atypical can remind you what kind of side effects are we going to have. Well, we're more likely to have side effects of typical antipsychotics. So extrapyramidal side effects, especially at 6 milligrams a day or higher, and cases of tardive dyskinesia. You can have orthostatic hypotension, especially at lower doses, and the FDA max is 16 milligrams a day, but no benefit is seen over that, and usually we kind of stop around 8 milligrams because it just increases the risk of side effects. But the FDA max is 16. Because it's the typical atypical, you also can guess that it's a 2D6 substrate, so you know it's going to have similar drug interactions to our typical antipsychotics. One of the advantages of this drug is it lacks anticholinergic effects, has a very low risk of hyperglycemia and weight increases compared to other atypicals. The disadvantages are extrapyramidal side effect risk, twice-a-day dosing versus once a day, and hyperprolactinemia risk. And it is also approved for irritability associated with autism in children, which cannot be said for most of our other atypical antipsychotics. Here's the receptor affinity for Risperdal, which if you remember clozapine, there's a lot less receptors on here. So it is basically D2, some serotonin, and then alpha, which this alpha is usually low, especially at higher doses. So that orthostasis risk usually is gone after a week or two. Risperdal Consta is a long-acting version of Risperdal. So it is given every 2 weeks. It is the first long-acting atypical antipsychotic. It uses what they call microsphere technology. So it's basically small spheres of Risperdal dissolved in water that you inject into the patient, and it can be more tolerable than the oil-based typicals because it's a water-based one. and it just slowly releases the Risperdal continuously over a 2 week period, or I'm sorry, over the duration of the medication. It's given every 2 weeks. You overlap with medication at least 3 weeks, preferably 6 weeks, because that's how long it takes for Risperdal Consta to reach an adequate steady state. And the dosing is 25 milligrams for the first shot, and then you can titrate up to 50 milligrams if needed. The cost of the Risperdal Consta is lower than the other ones, but you have to keep in mind that this is the only every 2 week shot. So 2 Risperdal Constas is the same price as our other atypical antipsychotics that are on the market, which are going to run you $2,000 to $3,000 per month. They're covered on most insurances if your patient has it. Usually it'll say a prior authorization required, and you tell them, it'll say, have they tried other antipsychotics? You list a few that they've tried, and do they have compliance issues? And you say yes, and boom, it's covered. Very easy prior authorization process if they have one. Most of the ones that we use now, they don't have any PA required, because it might be painful for them to pay $3,000 a month for that prescription, but that's a lot less money than it pays for the patient to be at an inpatient psych hospital. Perseris is the second long-acting risperidone injection approved for the market. It was approved in 2018 as a once-monthly subcutaneous injection. The claim for it is that it gives clinically relevant levels of risperidone after the first injection without a loading dose. And the doses are 90 milligrams or 120 milligrams, which equate to 3 or 4 milligrams daily. That right there would be the drawback of this medication. We actually haven't used this one yet because we don't have a whole lot of patients who only require 3 or 4 milligrams daily. Now, for patients who are outpatient or who require those levels, that might be great. I mean, that could be a really good option. But our patients usually require 6 to 8 milligrams of Risperdal daily, and I haven't seen anything about giving 2 of these shots. Giving 2 of the 120 milligram at the same time for 4 milligrams daily. So we just don't use this one a lot. I think it's probably a really good option for outpatient or for kind of more mild cases of schizophrenia. It has the same side effects, contraindications, cost, and precautions as the Risperdal Consta does. Paliperidone ER or Invega. Paliperidone is the active metabolite of risperidone. The dosing is 3 to 12 milligrams daily, once daily dosing. There's no benefit to twice a day dosing over once a day dosing. I'm starting to see that more and more. People are thinking, oh, well, that way we get a better steady state coverage. But because of the design of the tablet, which is an osmotic tablet, which causes like 24-hour release, it's just not true. The better control, but if you're having to, it's not going to hurt the patient to give twice a day dosing. The problem is going to be insurance covering that. If you're trying to give 3 milligrams in the morning and 9 milligrams at night for a total of 12 milligrams, insurance isn't going to cover both of those. So you may come into trouble with that. Because it's that osmotic tablet, it cannot be crushed or chewed. It has to be swallowed whole. It doesn't have any drug interactions to note, which is great. It definitely gives it a leg up, and you have to dose adjust in renal impairment. We use a lot of Invega. It's very popular because of that once a day dosing and because of the lack of drug interactions, and it seems to be very, very effective. As it usually has the same side effects of risperidone, with EPS being the exception. It seems to have a lower risk of that, and it has a more potent antidepressant effect than risperidone. Paliperidone, you can see its receptor affinity here. It's about the same. It's got a little bit more serotonin in there, but for the most part, it's kind of similar to Risperdal. Paliperidone palmitate is Invega Sustenna, the long-acting version of Invega. Is very popular. This accounts for like 2/3 of our drug budget at the pharmacy. Because it is a It starts out as given as a loading dose, 234 milligrams, and then 156 3 to 7 days later into the deltoid. It's given into the deltoid for earlier drug release compared to the gluteal muscle. 1 month later, you give a set 117 between 117 and 234 milligrams monthly. No oral supplementation is needed because of that loading dose. And you can refer to the package insert if a patient missed a dose. And that depends on if it's been up to 2 weeks, go ahead and give them the next one. If it's been up to 6 weeks, you give them a small loading dose. And if it's been over 12 weeks, you start the 234 and then 156 over again. But refer to that. They've got a nice schedule to follow. Now, one shot of this medication stays in the system for 3 to 4 months, but you still give it monthly to keep those adequate serum levels. I have a link on Canvas, I believe. The makers of Invega, Janssen, has a dose adjustment website where, let's say a patient was on 117 milligrams weekly, or monthly, and you want to go up to 234. Theoretically, what would the serum level do if you do that? Or comparing deltoid versus gluteal muscle injection. It's really cool, especially if a patient who says, I'm not getting it in the gluteal muscle at all. Give it to me in the deltoid. You can kind of see what adjustments you may need to make to the medication, if any. So it's actually a really cool website. So, Invega Sustenna is FDA approved for the inclusion of delaying time to relapse versus all oral antipsychotics on the drug label. It's the only trial so far, with the link below, looking at that, proving long-acting injectables superior to oral medication. Now, this actually compared Invega Sustenna to oral medications, including oral Invega. It also delayed the time to psychiatric hospitalization or repeated arrest and incarceration. The study followed 444 adult patients with schizophrenia that had recently been taken into custody or jailed at least once in the previous 2 years. So these are real-world patients. Many participants also reported substance or alcohol abuse and had a current diagnosis of a substance abuse disorder. Participants were randomly assigned to monthly treatment with paliperidone palmitate or paliperidone, perfenazine, which is a medium potency typical, risperidone, haloperidol, aripiprazole, olanzapine, or quetiapine. So you had a broad range of oral antipsychotics, including the oral version of Invega Sustenna, and it still was statistically better and had a delayed time to relapse or psychiatric hospitalization or arrest and incarceration. So it's great evidence for Invega Sustenna. It's also good evidence for our long-acting injectables overall because it helps with compliance. They also delay the time to relapse. Invega Trenza. This is the only drug on the market that is an every 3-month injection. It is an every 3-month injection version of Invega Sustenna. You have to be on a consistent dose of Invega Sustenna for 4 months because this drug can be in the patient's system for up to 18 months. So if they have a negative outcome, it could be a long time of treating that negative outcome before the drug is out of their system. But this every 3-month version is a great carrot to dangle for your patients of saying, if we go on an injection, you only have to get one for a year. And that'll help with compliance. You don't have to see me as often, less appointments. You don't have to worry about your meds. That's a really good kind of goal for your patients to have. The great thing about this is that Invega Trenza is exactly 3 times the cost of Invega Sustenna. So because of that, it's been fairly well received on insurance plans also. So there's no increased cost for that every 3-month option for insurance companies. So the patients we have on it, it's been pretty easy to get them switched from Invega Sustenna to Invega Trenza if we feel like they're a good candidate for that. Zyprexa or olanzapine, it is chemically similar to clozapine. You'll hear it called like its chemical cousin. It has a low risk of extrapyramidal side effects, even at high doses. It does have a high risk of cardiometabolic side effects. You see up to even 100 pounds gained on Zyprexa. Not necessarily. I've seen some patients going up to really high doses of this, much higher than the FDA recommended max, who don't have any side effects. But if they start having it, there could be a lot of weight gain and a lot of Zyprexa-induced diabetes. It is effective for schizophrenia, bipolar, and depressive disorders. So it's very effective, but causes a lot of side effects. So you're gonna kind of see that those two linked together, effect and side effects linked together. Dosing. Starting out at 2.5 to 5 milligrams a day, titrating up to 10 to 40 milligrams daily. I've even seen up to 80 milligrams tolerated in patients, sometimes in divided doses. You may want to divide it up so that they can take a higher dose at bedtime if it makes them sedated. It is available in an IM injection, a tablet, and a quick dissolving orally disintegrating tablet. That is not sublingual. It's not under the tongue, but it dissolves in the saliva, and then it's harder for them to cheek and spit out later because eventually they will swallow that saliva. The IM injection and IM Ativan must be separated by 2 hours due to risk of respiratory depression. So, side effects, big ones: metabolic changes and sedation. You're going to see those a lot. Obviously, metabolic changes take a while to take effect and to be seen, so that's why you want to do that metabolic monitoring, because it may not occur to somebody a year later to check somebody's lipids or A1C after they've been on Zyprexa. You can also there's a lower risk, but you can also have LFT abnormalities. There are several cases of DKA, new onset diabetes, and weight gain of up to 100 pounds on Zyprexa or olanzapine. It is very common. It has drug interactions because it's a 1A2 and 2D6 substrate. So again, very effective, but a lot to take into account when we're giving it to a patient. Here's its receptor affinity. It's one of the only ones with this 5-HT2C receptor. A lot of serotonergic activity, lower dopaminergic activity, and then over here you're seeing the side effects. And sorry I didn't mention this earlier. This X receptor right here, that is, they indicate a receptor that potentially unknown, because these drugs may be working on receptors that we haven't discovered yet, or we haven't realized that we've seen the receptor but we don't know it works on it. That may increase the risk of metabolic side effects or something like that. That kind of gives us that inner patient variability of these medications. Zyprexa Relprev is the long-acting version of Zyprexa. The patient must be watched after administration for a post-injection delirium or sedation. Enrollment in a patient care program is required, and the manufacturer actually has stopped marketing this drug. So it's still on the market, but they don't spend any money on advertising. And if you know anything about drug companies, they love to spend money on advertising. So because when this patient was coming to market, 2 patients actually died because of that post-injection delirium and sedation syndrome. The belief being that the medication basically dose dumped into their bloodstream and caused respiratory depression. So it is available. We have actually never used it, and if there was a good long-acting version of Zyprexa on the market, I think it would rival Invega Sustenna as being the top used overall. But this one's just not used very often because of that. I haven't seen it even talked about recently. Quetiapine or Seroquel is the least potent atypical. You can tell that doesn't mean it's not as effective. It just means it needs higher doses to work. It has a loose binding to D2 receptors, so there is a risk of rebound psychosis or fluctuating efficacy if it's not given at a high enough dose. But it's still a very effective medication. You just want to give it, you can give it daily or twice daily. There's less risk of EPS and tardive dyskinesia, but it does cause sedation, orthostasis, weight gain, and mild anticholinergic effects. So this one, the biggest one for Seroquel is going to be the side effect of sedation. So please, you can use it for patients who need some sedation and don't sleep all night because of their psychosis. Please don't give this to a patient who just needs to sleep, and has no other psychiatric disorder. Why would you give an antipsychotic for a patient who just needs to sleep? Essentially, at 25 milligrams a day, it's only histaminergic activity. Just give a Benadryl. It's the same thing. Don't give the risk of the other side effects. So you can give up to an 800 milligram a day dose. It is a substrate of 3A4, which means it can have a lot of drug interactions. Lowest extrapyramidal side effects after clozapine, so it's a good option for patients it is an option for patients with Parkinson's. Do not use for sleep due to short-term and long-term adverse effects. And compared with other antipsychotics, it's very well tolerated. It does have less significant drug interactions, and it has lower weight gain and diabetes than clozapine and olanzapine. It does come in an extended release version. Seroquel already may be effective with once daily dosing because of that loose binding effect of the dopaminergic receptors. It doesn't appear that Seroquel XR is more effective than Seroquel and is much more expensive, because the thought is that the Seroquel will come in and bind to the D2 receptor. It'll release because it's only a loose binding. The antagonistic activity continues, and then the Seroquel can come in and bind again later on once the receptor is ready to bind dopamine. So it basically binds repeatedly as opposed to binding and staying. And what you'll read in your, I think the Stahl book talks about kind of the ringing the bell analogy, that when you ring a bell, even though you've rung it, it continues to ring and and resonates for a while afterwards. And that's what the thought of the Seroquel, why it's still effective even though it has a loose binding, is because it binds to that receptor and it continues to resonate and it continues to ring until it stops, and then the Seroquel can hit it again. So, we don't use, at our inpatient hospital, we took Seroquel XR off the formulary. We don't use it anymore. It's way too expensive, and it hasn't seemed to provide any effect. Here's the receptor profile, so you can see there's more receptors than the other atypicals we've talked about. Seroquel, as an antipsychotic, it kind of varies in which receptor is the most effective at a certain dose. This is the picture from your book. Whether when it's a low dose, 50 milligrams, it's mostly histaminic. Then serotonin, then goes up to serotonin 2A and dopamine as an antipsychotic dose. I'm not a big fan of the hypnotic here, because if I'm giving something that primarily has H1 activity, why would I not give somebody something that only has H1 activity? It's only an antihistamine, not also has these other receptors. But that's kind of where that receptor activity comes from. So ziprasidone, we're getting into, or Geodon. So it's highly bound to D2. Its dosing is 20 to 40 milligrams BID, titrated up to 80 milligrams BID. It can be activating to a patient if too low of a dose is used. So if a patient's already if they're manic, they can. You want to start with a medium level dose, and you have to take it with food. 500 calories is required for adequate absorption. If they do not take it with 500 calories, it won't be properly absorbed, and you're going to be like giving them water. Giving them Tic Tacs. It is not. It doesn't matter what kind of calories, but it has to be given with that many calories. So we have our patients take it with a meal. Most people don't eat 500 calories at bedtime. So we have them take it with breakfast and with dinner. for proper absorption. You can see the receptor profile here. Again, serotonin and dopaminergic activity. The receptor affinity is pushed towards dopaminergic, so that's why you'll see the side effects coming up here. No significant cytochrome P450 drug interactions, which is great. That was the first one we saw of these before Invega hit the market with no drug interactions. Side effects, usually well tolerated. It can cause anxiety at higher doses. It can prolong the QT interval. Does not need routine monitoring. You just want to use it in caution with medications that can prolong the QT interval also, or someone who already has an arrhythmia. And that interval prolongation is not dose dependent. Zyprexidone's claim to fame when it came to the market, was big thing was it was weight neutral. And it is. It has a very low incidence of metabolic side effects. So it's one option. Since then, we've had others come to the market that are weight neutral. A few, that can be good options. I don't think Zyprexa is as effective as other medications like Invega or Zyprexa, but it can still be a good option for your patients. So contraindications: history of QT prolongation, recent acute MI, uncompensated heart failure, and concurrent use of drugs that prolong QT. So just think, they got something wrong cardiovascularly, just skip Zyprexa. Sorry about that. Fanapt or iloperidone. Fanapt is a fairly new atypical antipsychotic. By new, I mean I think it's within the past 5 years. There's no advantage to this one over currently available products. It is name brand only. It costs about $1,400 a month, and I don't believe is covered by most insurance plans still. It's dosed 1 milligram BID, increasing to 4 milligrams daily, by 4 milligrams daily. Max dose of 12 milligrams POBID, metabolized through cytochrome P450, 3A4, and 2D6. Strong alpha-1 binding says it makes it think it may have utility in PTSD, somebody who has PTSD and schizophrenia. Low EPS and akathisia, and has a adverse effect of orthostatic hypotension, which is why we have that maximum increase of 4 milligrams a day for the taper. You'll see the receptor affinity here, some serotonin, dopamine, and then the alpha and histaminic. Again, we don't use a lot of Fanapt at our facility. We just haven't seen the benefit of it over other medications. I'm not saying that it's not as effective, but for a lot of our patients who are uninsured or have poor financial options, it's just not an option for us. I think it's a good option for patients who can, like some of the drugs we're going to talk about in a minute. I put them in that category of patients who can get a job but can't keep a job because of their symptoms, or might live at home but they can kind of do their normal daily living skills. They may have health insurance. They can function, but they still need some kind of medication. Less severe patients, it might be a really good one because of it's very tolerable. And they're able to afford it. Safris or acinapine, again, is another brand name only antipsychotic. It's less than 5 years old, I believe. It is a sublingual tablet that must go under the tongue for 10 minutes. They did finally make it a black cherry flavor tablet, but it still tastes terrible, according to the patients I talked to. It is really hard for a patient to keep that tablet under their tongue for 10 minutes and not eat or drink anything for the 10 minutes afterwards with that bad taste in their mouth. Which is why we haven't used a whole lot of it in our hospital. We've had a few patients who've been successful on it. Don't get me wrong, but we don't use it a whole lot because they have to be able to follow that 10-minute rule every time. The adverse effects are similar to other atypical antipsychotics, like we'll talk about. All of our penes, acinapine, olanzapine, clozapine, and quetiapine. It can cause weight gain. and drowsiness, and it is a low risk of EPS and akathisia. It is not absorbed if swallowed. It has to be sublingual. It may have antidepressant effects, but it's not FDA approved, and they believe this because it's structurally similar to mirtazapine or Remeron, which is an antidepressant. So, still could be a good option for your patients who have schizophrenia and depression. It is an option, but again, price is going to be a hard price, and compliance with the under the sublingual administration is going to be kind of your drawback. And here's the receptor. Wow, that didn't come up clearly at all, did it? But it's in your book. This is you can see it's just a big receptor affinity for saffrous. There is a transdermal patch of acenapine that was approved in October of 2019. It's applied once daily for sustained concentrations over 24 hours. That may solve that taste in the sublingual problem for a lot of patients. It is essentially considered the same as the sublingual tablet as far as safety profile and side effects go. You could have a possible application site reaction if they're sensitive to adhesive, but that's the same with every patch. If they have that reaction to Band-Aids, they're going to have it to a patch. It's just the adhesive that's on there. The adhesive for this patch is no different than any other adhesive. It's possibly useful for patients who have trouble taking acenapine. Could provide visual confirmation that a patient is adherent. At the point of when I made this PowerPoint, this slide's a little old. The cost was to be determined, but it's going to be similar to the tablet of saffrous. Lorazepam or Latuda is another one of your newer atypicals. It's again has no advantage over currently available products. You're going to see that for a lot of these, and again, I don't mean that it's not as effective. It's just not more effective. It's just because it's newer. None of these are more effective because they're newer and cost more. They're all fairly equally effective across a population. I think lorazepam is good for. Lorazepam is great for patients like we talked about earlier who don't require sustained inpatient treatment or who only require outpatient treatment, who have milder symptoms, milder cases, who because it's very tolerable, but it's just not quite as effective as our typicals or Invega or Zyprexa. So it's metabolized by 3A4. It is given with 350 calories for absorption. If it is not given with 350 calories, it is equivalent to half the dose of Latuda, which could be helpful when titrating the dose up if they just can't tolerate it, but it's more so to say it has to be given with 350 calories for proper absorption to be adequate. It is effective for schizophrenia and bipolar depression, which seems to be where it's really finding its niche in that bipolar depression. It has a very low risk of weight gain and sedation, and the 5-HT7 antagonism may be beneficial for mood, cognition, and circadian rhythms of sleep, but I don't know that that's really played out in any type of trial or study. That's just a thought that we know 5-HT7 receptors play a role in that, so maybe the antagonism may help in these, but I'm not sure that that's actually been seen. And you can see it has a very simple receptor profile, so it's pretty tolerable for our patients. We have a few who use Latuda, definitely more than the ones I've just talked about, the Fanapt and the saffrous. But I think this is a great outpatient antipsychotic because it's so tolerable and effective enough for those patients. Aripiprazole is the first atypical antipsychotic that is a dopamine partial agonist. So it acts as an agonist in the presence of a D2 antagonist, but is not as much agonism as pure dopamine. It also has 5-HT2A antagonism and 5-HT1 partial agonism. So it's usually pretty tolerable. The primary complaint is going to be akathisia, and that's going to be the biggest reason why patients stop taking the medication. Akathisia can be so bad that it can be a cause of suicide. in patients if it's just that intolerable. You can treat akathisia with a beta blocker like propranolol, or you may have to change the medication to get away from it. It is metabolized by 2D6 and 3A4, so you want to recommend dose changes with potent inhibitors and inducers of those two enzymes. It is approved for schizophrenia and adjunctive treatment of depression. It may provide cognitive and negative symptom relief through that serotonin antagonism. Also, because it is a partial agonist at dopamine, you're going to get some dopaminergic activity. So it could help lessen the negative side effects of the medication. In practice, we have seen either aripiprazole works or it doesn't. It is there's not a whole lot of in between. It seems like, it is very effective for some, and some you just think, wow, they're going to need more antagonism than what aripiprazole can provide. And when you have, let's say you're going to give two medications, two antipsychotics, the partial agonist, aripiprazole or brexpiprazole, we'll talk about in a minute, is always going to preferentially bind over the antagonist. So if you were to give Abilify and Haldol, aripiprazole is going to exert its action before the Haldol does, which is why we'll talk about in a few minutes. When you're titrating from one to the other, you have to take that into account, or adding a second antipsychotic to Abilify doesn't seem to provide as much benefit as if you were adding it to another antipsychotic. But it can be done. You can give it but it's just not as much benefit. Aripiprazole is a partial agonist. You can see here, that's where that change is. You can see it's not the full triangle or cone of the D2. It's just a partial agonist. It has long-acting injectable versions. Abilify Maintena is given 400 milligrams every 4 weeks. Aristada is given 441 milligrams to 882 milligrams every 4 to 8 weeks based on the PO version. Now, the PO dose that they're taking. Now, where do these two fit, and why would you pick one or the other? So, according to the data that was submitted to the FDA for approval, Abilify Maintena 400 milligrams gives a higher serum level than the highest dose of Aristada. So, if you have a patient who takes 20 milligrams or more of aripiprazole, I believe that's where Abilify Maintena should be used, because Aristada's highest dose is equivalent to about 20 milligrams, whereas Abilify Maintena is about 23 to 24, 25 milligrams of PO on average for each patient. What the benefit Aristada might have is for patients who require lower doses than that. So if they only require 10 milligrams or 15 milligrams a day, that's where Aristada can come in, because then you don't have the risk of giving too high of a dose like Abilify Maintena. So neither one provides a benefit over the other. You both dose adjust for 2D6 drug interactions, and they both need PO overlap. But one of the drawbacks of Aristada, where they say this up to every 8 weeks, only a certain dose gets to do the every 8-week dosing. Most patients are still going to have to do every 4 weeks, so it doesn't really provide that benefit. It's just the every 8 weeks is not going to be an option for every patient. And they have equivalency charts that are available that if you take 5 milligrams a day, you take 441 milligrams every 4 weeks. If you're 10 milligrams, you can do these doses and on up. So Aristada provides a way to dose adjust for lower doses, but it doesn't provide as high of a serum level as Abilify Maintena. And in the Canvas class, there are comparisons of long-acting injectables, and there's more resources there. So I would highly recommend getting those, saving them to your computer so that you can use later, or go ahead and printing them out. Do whatever you want with them. Most of them I made personally, or we made with students who came and worked with us, and you can do whatever you want with them. Brexpiprazole is another partial agonist for D2 receptors. It is indicated for schizophrenia and adjunct in major depressive disorder. Similar side effects to aripiprazole, maybe less akathisia. It's just slightly less of a partial agonist than Abilify, and is a substrate of 2D6 and 3A4. And you can see that its receptor profile here and what it does. Now, I will say we have never used brexpiprazole in our hospital. Rexulti or brexpiprazole is made by the same manufacturers as Abilify, and I'm sure it's just coincidence that brexpiprazole hit the market right before Abilify was going off of was about to go generic and losing its patent. I haven't seen a big benefit of brexpiprazole over Abilify, but there may be some patients that do have that benefit, but I just haven't seen the need to the benefit for the cost. Cariprazine or Vraylar is indicated for schizophrenia, manic mixed episodes of bipolar 1. It is a D2 partial agonist, 5-HT2A antagonist, and a D3 antagonist. Now, the thought might be that might help with some other symptoms, some cognitive symptoms. As someone tried to tell me one time, it might be motivation in a pill, for negative symptoms and some cognitive symptoms. I do not want you to leave this class thinking that Vraylar is motivation in a pill. So far, the D3 antagonism doesn't seem to be playing out like most people think it would, but it's still good for schizophrenia symptoms. It's dosed as a once daily capsule. It is a substrate of 3A4, so you want to reduce the dose to half the usual dose if they have a strong 3A4 inhibitor, and do not use it with 3A4 inducers because it will metabolize it too much. Very low incidence of side effects of EPS and akathisia, so it's tolerable. It's expensive. It may help. All the patients we've put on Vraylar, we haven't seen those extra benefits that some of the that were speculated for that D3 antagonism. It is the first one with D3 antagonism, but it just doesn't seem like that's playing out like they thought it would. So, pimavanserin or Nuplazid is the first non-dopaminergic antipsychotic. It is approved for psychosis associated with Parkinson's disease. It is given as a 34 milligram daily dose, reduced if they have a 3A4 drug interaction. It's very well tolerated in trials. More data is coming out with increased usage, and the biggest risk may be QT prolongation. Now, it is only a serotonergic antipsychotic. It does not have any dopaminergic activity. It still carries the black box warning for increased death in dementia patients, but they are trying to study it in dementia patients. So it is looking at they're looking at more trying to get more indications for it, which is very interesting. So concerns are still being raised about the common side effects and the efficacy of it. So ISMP is looking at the most frequently reported side effects, with 1/5 of the patients reporting hallucinations and 15% saying the drug was ineffective. Now, it does cause me concern that 1/5 of the patients report hallucinations, which is what this medication is supposed to be treating. But they're concerned that pimavanserin was approved even though it showed minimal treatment effect, caused twice as many side effects as other medications in trials, and only showed benefit after 3 previous failed trials. Now, there's been a little bit more evidence coming out that I don't think they're going to pull it from the market or anything, but I don't think I hesitate to use it for a large number of patients. They do have the Harmony trial that was looking at the safety and efficacy in treatment-related or dementia-related psychosis, not any specific form of dementia. The results showed statistically significant longer time to relapse versus placebo, and the trial was stopped early due to positive results. The manufacturers of pimavanserin submitted to the FDA for this approval, but it was denied as of March 3rd, 2021. They are still trying to revamp some things and get approval. But as of now, nothing has been, they were denied the approval for that indication. They're trying to get that because they want to be the only one that's for dementia-related psychosis, because there are a lot of behavioral side effects of dementia and psychiatric side effects of dementia. So that they're looking for that niche that they can carve out for themselves. Lumateperone, or Caplyta, is our newest antipsychotic. It was approved in December of 2019 for treatment of schizophrenia. Two studies at 28 days of treatment, which is common for antipsychotics. They don't do long studies. Still has the black box warning for increased mortality in elderly patients with dementia-related psychosis. And its mechanism of action is antagonism of serotonin 5-HT2A receptors and postsynaptic antagonists of D2 receptors. It is believed that I'll get to that. Sorry, I'll get to that comment on the next slide. The most common adverse reactions were somnolence and sedation and dry mouth. Pooled data from a short-term trial showed similar changes in weight gain, fasting glucose, and total cholesterol compared to placebo, which is good. The incidence of extrapyramidal symptoms was similar to placebo, which is great. The dose is 42 milligrams. It's a consistent dosing. You don't have to adjust, which is great. The cost is $1,400 a month, which is not so great. It is believed that with Caplyta having a high affinity for serotonin 5-HT2A, which is 60 times higher than D2, the dopaminergic, makes it more tolerable. It has a moderate binding affinity for D1 and the serotonin reuptake transporter. It has a low binding affinity for muscarinic and histaminergic, which seems to make it tolerable. Now, that D1 receptor affinity is why it is thought that there's down the line this may also affect AMPA and NMDA, which would then cause some efficacy or effect on glutamate. Now, if you talk to a drug rep for this medication, they don't have proof that it that it alters glutamate. They're not allowed to talk about it. But in theory, people are wondering. You can find articles about that. It may be true, and that would help a lot of patients. That's a neurotransmitter that we are slowly learning more and more about, and we are going to start targeting more and more. I think. We've had some patients on this. Some have had good success. Some have not. It's another option, but it seems to be very well tolerated. And down here you can see that the binding of Caplyta to the D1 receptor may contribute to indirect activation of the AMPA and NMDA receptors, which would then increase glutamate, possibly cause neuron reactivation, and help with symptoms even more. You can see the high affinity, so it is a much higher affinity for serotonin than any other receptor, which is what makes it so tolerable. Long-acting injectable antipsychotics. So those are all of our antipsychotics individually, oral and injectable. But we're going to talk for the next so many slides. We're going to talk about kind of groups of them. So long-acting injectable antipsychotics. They require several months to reach steady state with different times for oral overlap. There is a theory in theory, they increase compliance. We're starting to get evidence of that, and effectiveness. We're getting evidence of that with the study on Invega Sustenna. Less EPS and side effects. We're finally getting trials to show this. EPS and side effects seem to be less with long-acting injectables because it seems that instead of having the peak and trough of oral, you have a lower. It keeps the peaks from being so high and the troughs from being so low with an injection of a slower, more steady release. Again, the Haldol and Prolixin long-acting injectables are just the drug dissolved in sesame oil, which can be more abrasive to the skin. Not a reason not to use it, but we see higher injection site reactions with that. And atypicals mostly have an aqueous base and are designed for slow metabolism of the prodrug. So most of them are, say, Invega Sustenna, and they attach on that big palmitate particle, and as the body cleaves off the palmitate and gives us active paliperidone, it goes in the bloodstream and it can do its thing. So that's how they've designed them. As opposed to the oil dissolving slowly, it slowly cleaves off that side chain. Long-acting injections, on average, the adult patients are treated on 4 different oral long antipsychotics before starting a long-acting injectable. Luckily, that is changing. We need to start pushing for more and more long-acting injectable use, because when patients are hitting 10, 15 years of oral medication up and down, on and off before a long-acting is started. So we need to start using it more. We talked about that study versus the commonly prescribed oral medications. This is more information on that. Long-acting injectables, there's also a study showing a 30% lower risk of first treatment failure with a long-acting injectable, a 6-month longer delay in time to relapse with a long-acting injectable, and a better median time to first psychiatric hospitalization on long-acting injectables. Now this is going more in depth on that Invega study where they screened them, either put them on long-acting Invega or these oral medications, including paliperidone, greater than 6 months longer to time to treatment failure. Secondary endpoint was not reached. Time to first psychiatric hospitalization was significantly longer versus commonly prescribed oral antipsychotics. When it means it was not reached, was they didn't have enough hospitalizations or arrest in the Invega Sustenna by the time they capped it. So like they still, if the trial had kept going, they would have looked for that day. But after 450 days, they still had too few of those, which is good. Frequencies of first treatment failure, you can see here better percentages for the long-acting injectable. Why it was a real-world design, I'll let you read more in depth in that, but it was a very well-designed study comparing Invega Sustenna to oral medications. Now, how do you so we talked about all of these medications with their different receptor affinities and different side effects and all this kind of stuff. How do you keep them kind of separated in your mind as you slowly use them and build up your knowledge through practice? Because there's only so much you can learn from looking at PowerPoints and listening to me drone on and on. So how do you do that? Well, remember them as typicals or first generations as one group, and then your atypicals in general as your penes and your dones. So your penes, clozapine, quetiapine, acenapine, and olanzapine, they're more sedating, they have more cardiometabolic risk, and they're titrated slower due to orthostasis. So at least a 2-week titration up to the maximum dose, much longer for clozapine. Your dones, paliperidone, risperidone, ziprasidone, lorazepam, they have more typical activity. So they have more prolactin increase, more extrapyramidal side effects, and they can be titrated faster over 1 week because they don't have as much orthostasis. So your penes and your dones will help you keep in mind which ones are which, and then for your penes, you can kind of, from some charts later on, you can kind of remember, quetiapine has the most sedation, olanzapine has the most weight gain within those penes, but I know that risperidone has much less than all of them. Keep them with your penes and your dones. Switching antipsychotics, which you will do a lot of. Remember that you may need benzodiazepines or PRN antipsychotics during the switch. Concomitant titration is best, so don't take them all the way off one antipsychotic to start another one. But always keep in mind that D2 partial agonist will knock off the antagonist, so start with an adequate medium dose of the antagonist of the partial agonist. So if you're putting them on Abilify, give them a hefty dose, because you don't want Abilify 5 milligrams knocking off the adequate level of Haldol they were already taking. So, switching antipsychotics. I took these from your book, so you can refer back to your book at any time on how to switch these. So you can see going from a peen to a done, you're going to titrate the peen down slowly because you don't want rebound hypertension or rebound side effect, the reverse of the side effects these can cause. And then you're going to take the done up over 1 week. So at 1 week, they're at the full dose of the done and they're at a half dose of the peen, and they're going to keep coming off of it. If you're switching from a done to a done, you can do it all over 1 week for both of them. If you're doing from aripiprazole to a done, you want to stop the aripiprazole immediately and start with a middle dose of a done. Okay? Because that aripiprazole, if they've been taking it, if you stop it today, they're still going to have it's still going to take 5 half-lives, or about a week, for that drug to get out of their system. And in general rule in pharmacology, 5 half-lives to get to a negligible amount of drug in the system. So over a week, you're going to start with an adequate dose and titrate them up so that by the time they're at 0, it's at an adequate dose. So you're still getting an effective amount of D2 blockade. Same thing with an aripiprazole and a peen. You want to stop it, start with a good middle dose of the peen, and still go up over 2 weeks as that aripiprazole comes out of the system. We're titrating the peen up from a middle dose to an adequate dose. So we've got peens to dones and peens to peens. You can actually do over 1 week because you have the same side effects with both of them. So if that makes sense, you're trading orthostasis for orthostasis. So go ahead and do it over 1 week. Aripiprazole to a done, you want start at a middle, not a low dose when adding aripiprazole, and take the done down over 1 week. And same thing here. You want to start at a middle dose of aripiprazole and take it up quickly and take the peen down over 2 weeks. Clozapine is the exception. You are going to always stop clozapine slowly because you're going to get rebound side effects. If you rebound hypertension, if you stop cholinergic rebound, if you stop it so quickly, so you can get rebound psychosis, hypertension, and cholinergic rebound if you stop it slowly. So you want to start and stop clozapine slowly, at least over a 4-week titration. That's the one exception to all of these. Multiple antipsychotics. Again, if you're switching antipsychotics or you're using multiples and you have questions about specific combinations or whatever, feel free to email me at any time. You can, not even just during the class, just afterwards. I've probably seen every combination there can be, and three antipsychotics even if we need to. So we can talk about that. 1 out of every 4 outpatients and one half of inpatient patients will require multiple antipsychotics. You only want to do it when monotherapy trials fail, and possible options are suggested for if you need augmentation of clozaril, so you need a little bit more D2 activity to go along with the clozaril. You can do a typical and an atypical. I don't recommend 2 typicals. Or you can do 2 atypicals with different receptor profiles. So maybe a peen and a done, to get additive D2 and serotonergic activity. If you have patients with cognitive impairment, studies have shown antipsychotic medication early in schizophrenia may improve cognition. Currently, there are medications being studied for this indication, but some that have failed to show benefit include NMDA receptor agonist, all your treatments for dementia, and some other medications that we don't use commonly in psychiatric illnesses. Something that I think is very interesting, I'm not going to go too in-depth on it, but I highly suggest you read the CATIE trial, or the Clinical Antipsychotic Trial for Intervention Effectiveness. Now, there were multiple phases and multiple papers that came out, and but the main point of the trial, it's a very good trial, very real-world trial, comparing, the first phase compared perfenazine, so medium potency typical, to all the atypicals that were currently on the market at that point. It was up to 18 months of treatment, and 74% of patients discontinued treatment due to inefficacy or intolerable side effects, regardless of which antipsychotic they were put on for the most part. So the typical was not more or less effective or tolerable than the atypicals. Time to discontinuation was looked at for this medication because if they don't take the medication, it can't be effective. Time to discontinuation was similar among all groups when it was due to intolerable side effects. For the most part, when clozapine was taken out of it, olanzapine had a slightly longer time to discontinuation. Compared to clozapine in the second phase of the trial, clozapine had a average time to discontinuation of about 11 months. The next closest was olanzapine at 4. And perfenazine had similar time to all the other atypical antipsychotics. So there's a lot that can be gained from this, saying that it is not necessarily true that typical antipsychotics are more or less tolerable or effective than atypicals, and that what we know is that clozapine is the most effective, including time to discontinuation, but it can't be used for all patients. Then after that, there's not really much of a difference. The one drawback to this trial is that olanzapine was allowed to be used at a slightly higher dose than normal, which may contribute to its longer time than other atypicals. In summary, time to discontinuation was highest for clozaril, which was good for clozaril. You want a longer time to discontinuation. Then Zyprexa slightly at about 4 months, and then all the others were equal at about 2.25 to 3 months. But discontinuation was around 75% regardless of the medication. They even had a phase where the prescriber and the patient got together and picked which medication they wanted. It wasn't blinded. They got to pick which one they wanted. They knew what they'd already had, and it was still a 75% rate of discontinuation. So discontinuation is a common problem with antipsychotics. Neuroleptic malignant syndrome, or NMS, is something you're going to have to watch out for with antipsychotics. The side effects are, you can remember fever, encephalopathy, vital sign instability, elevated white blood cell count and CPK, and rigidity. It is caused by dopamine antagonists. There's a very high risk of mortality if not treated, and the risk factors are concomitant agitation, dehydration, parenteral administration of antipsychotics, not long-acting injectables, but immediate-acting Haldol, Zyprexa, Geodon, rapid titration of doses, and higher doses of medication are risk factors for that. Treatment is going to be the discontinuation of the antipsychotic, supportive care of hydration and temperature control. You can give bromocriptine or dantrolene, and you wait at least 2 weeks before reinitiating with an antipsychotic. Typical antipsychotics are more likely to cause NMS, but atypicals have also been associated with it. It is uncommon, but it is very serious, and it's more common in men and patients under 40 years old. Pharmacogenomics, we talked about this in the intensive, so I'm going to skip these, but it is helpful for patients who with psych disorders because of there's so many drug interactions. Here is a chart for long-acting injectables that I think it's a really good one. What does it require a loading dose? What injection sites are options? You can see some are deltoid and some are gluteal, some are both. Time to steady state, to a steady serum level, and what the dosing interval may be. Here's another one down below that you may prefer this one over the other one. Either one's fine. It's just kind of what's on there, how they're broken down, the Zyprexa Relprev, the Aristata. It's just another resource for you. Here's a chart comparing the estimated QT prolongation or the approximate QT prolongation for antipsychotics. You can see here that the only one that's really high, the ones that are high by themselves are ones that we don't use in America anymore, and then thioridazine at high doses. The next one is Zyprexa up to about 20 milliseconds, and then Haldol up to 15, with those higher numbers being usually due to IM injections over oral. QT prolongation risk, also in combination with other medications, which antipsychotics, and which ones are more common. It appears that iloperidone or Fanapt may be more comparable to ziprasidone and haloperidone, but I don't quite have that information, that number available. And lorazepam and paliperidone are insignificant for QT prolongation. So on Canvas, I have some Excel sheets that will print to like 1 page front and back that combine a lot of this information into one sheet, so you don't have to have a page for long-acting injectables, a page for QT prolongation, a page comparing risk of side effects, like this one here, which one's the best choice if you want to avoid sedation, weight gain, or EPS. D2 receptor affinities for medications, therapeutic effects of certain receptors. These right here are for your information. We don't need to go over them. I'm not going to ask you on the final exam, okay, tell me which one of these is 3+ receptor affinity for the 5-HT1A receptor. I'm not going to ask you that. This is for you to be able to keep with you, especially in those documents that are on Canvas, so that you can pull them out real quick and compare them. Or if you get a new medication and you think, okay, it's the receptor affinity, this is the receptor affinity, how does it compare to olanzapine? Side effect profiles for them, common drug interactions for these medications and the substrates. Again, all of this, they're in easy to print, front and back versions. Hypothermia risk, which is not commonly thought about, but it does happen, and there is a fairly high odds ratio. So, so somebody taking fluphenazine so let's do thyroidazine. They're 6.9 times more likely to have hypothermia than somebody who's not taking an antipsychotic. So there's not many case reports. This was pulled out because we actually had some patients who became hypothermic on antipsychotics, and we had a medical resident do a case study on this, or a literature review, and found this really good reference. So if you have had a patient who has hypothermia on an antipsychotic, this kind of tells you at least maybe ones to target in the future. Real quickly, VMAT2 inhibitors, they are used for treating tardive dyskinesia, which are the first medications that we have for treating this. You can read through this, but the two that are approved for tardive dyskinesia are Austedo and Ingrezza. They are very expensive, depending on the strength, several $1,000s a month, but they are pretty effective. They work by inhibiting the VMAT receptor, which results in decreased uptake of monoamines into synaptic vesicles and depletion of monoamine stores into the nerve vesicles. So it gets more neurotransmitters out here into the synapse. You can read over these just for your information, how to dose them, possible side effects. We have had a couple patients put on these for horrible tardive dyskinesia, and they really do seem to be pretty effective. It's not going to get rid of all of it for everybody, but we've had patients with the lip smacking and the limb movement that some of them have gotten to where they don't have any noticeable tardive dyskinesia, and for the ones who don't, it's a fairly noticeable decrease. So I'll let you read these. This is more for your information, so that you can kind of get familiar with these and their use and how to prescribe them. So that is antipsychotics. Made it just under 2 hours. This is by far our longest lecture. None of them will be 2 hours anymore. That's why we have two weeks for this module. If you have any questions, please let me know. Please go through the resources, the documents on Canvas. There's a lot of really good stuff that I slowly add to it when I find good resources and articles on there. If nothing else, save them to your computer, and so that you can just search through them later on in your practice. If you have any questions or anything, shoot me an email, and I'll see you when we talk about bipolar medications.